With the approval of 2 new BRAF inhibitors and study findings on the success of combination therapies, the treatment options for metastatic melanoma are expanding. At ASCO 2013, Dr. Lynn Schuchter, a melanoma expert at the University of Pennsylvania, discussed the impact of the latest research.
Now we have this, wealth of options to consider for patients. Do we consider using immunotherapy first with ipilimumab or enrolling patients on a PD-1 clinical trial, or do we consider a targeted therapy approach first? And that really is a decision about how well is the patient, how sick is the patient. So patients that have pretty significant disease burden, are sick from their melanoma, most clinicians would start with a BRAF inhibitor first. That has the highest response rate and the most rapid shrinkage rate. So if it's critical to get a fast response rate, we would start with targeted therapies. If patients don't have very much disease and are relatively asymptomatic, then I think most would favor starting with an immunotherapy approach. Of course, I always recommend enrollment on a clinical trial. This is how patients get access to some of these newest agents. And at this year's ASCO, the ipilimumab plus PD-1 antibody study is also going to be presented. And that combination, again, combining immunotherapies, also looks very exciting with very high response rates. And again, I would say surprisingly, not too many side effects when we combine the two. It's a lot of alphabet soup and for everyone to understand, but these are 2 now broad classes of treatments to consider in melanoma: targeted therapy for BRAF mutant patients, immunotherapy as well. And the third paper is a MEK inhibitor for patients with uveal melanoma. So in uveal melanoma, ocular melanoma, it's a different genetic profile. Some patients have a GNA11 or GNAQ mutation in their melanoma, and it was predicted that MEK inhibitors would be useful. So another paper that's going to be presented at this year's ASCO is looking at the MEK inhibitor in patients with uveal melanoma. And compared to chemotherapy with temozolomide, the MEK inhibitor looks to be an advantage. So that paves the way for finally therapeutic options for patients with ocular melanoma as well.
So several pathways being exploited. Are there others?
Absolutely. So another paper that will be presented is more information about the somatic mutations that occur in melanoma, and more is being learned. We know that c-KIT is frequently mutated in melanoma, but we are learning more and more about different mutations, and that, of course, opens the door to consider new targeted therapeutic approaches. So it's critical that we comprehensively evaluate a patient's tumor and look at what the mutation profile is so that we can more effectively find the right clinical trial or agent that would be useful for a patient. Amazing in 2013 is that chemotherapy is not the first or second choice for patients with melanoma. It's really targeted therapies if appropriate, or immunotherapy. So chemotherapy, which was the only option we had just a few short years ago, is really third choice now for patients with advanced melanoma.
Lots of new options and lots of new pathways to pursue.
Exactly.
Very exciting. Thank you so much, Dr. Schuchter.
My pleasure. Thank you.